Hello and welcome. We will continue where we left in previous part. So, let's start. The learning objectives are shown. Please take a look. Benzodiazepines are now the most commonly used sedative hypnotics. They increase the frequency of chloride channel opening at GABA-A receptors and are safer than barbiturates. Flumazenil acts as a competitive antagonist. Benzodiazepines produce sedation, anxiolysis, hypnosis, muscle relaxation, and anticonvulsant effects. Medullary respiratory depression is uncommon, which explains their improved safety. Different benzodiazepines are classified based on duration of action that also determines their reason for being chosen to treat certain conditions. Short-acting agents are used for sleep onset, while longer-acting agents are useful in anxiety, seizures, and withdrawal syndromes. Many benzodiazepines undergo hepatic metabolism with active metabolites. Lorazepam and oxazepam are safer in liver disease because of their limited metabolic requirement. This slide reinforces the importance of hepatic metabolism and explains why elderly patients are more susceptible to accumulation and adverse effects. Please note that lorazepam and oxazepam have a simpler metabolic process. Adverse effects include daytime somnolence, cognitive impairment, psychomotor slowing, and additive CNS depression with alcohol. Dependence and withdrawal can occur. Lethal dose is high, contributing to safety. Zolpidem, Zaloplan, and Zopiclone are non-benzodiazepine hypnotics that selectively bind BDZ1 receptors. They induce sleep without significant anxiolytic or muscle relaxant effects. Hay are drugs of choice for sleep-onset insomnia. Short half-lives minimize morning hangover. Their toxicity profile resembles benzodiazepines, and flumazenil is effective in overdose like in benzodiazepines. Chloral hydrate is a prodrug metabolized to trichloroethanol, which enhances GABAergic inhibition. Due to its narrow safety margin and cardiopulmonary toxicity, it is now largely obsolete. Meprobamate likely modulates GABA-A receptors but has a low margin of safety. It causes dependence and severe withdrawal and is no longer routinely used. Buspirone is a 5-HT1A receptor stimulant used for mild to moderate anxiety. It does not cause sedation, dependence, or withdrawal, but has a delayed onset of action. The side effect profile is very favorable as compared to GABAergic drugs. Melatonin regulates circadian rhythm through the suprachiasmatic nucleus. Darkness stimulates melatonin secretion by pineal gland in the brain and it induces sleep. Disturbances in this system cause insomnia, particularly in jet lag and shift work disorders. When our eyes see light, especially blue light, it stops melatonin release and sleep induction is delayed. Melatonin receptor stimulant Rimeltion is an MT1 and MT2 receptor agonist used for sleep-onset insomnia related to circadian rhythm disturbance. It has minimal abuse potential but may cause endocrine effects. The hypothalamic neuropeptide orexin maintains wakefulness. Antagonists such as suvorexant and daridorexant reduce arousal and are effective in sleep maintenance insomnia. These drugs are relatively a new class of drugs for sleep disorders and has a targeted approach of just switching off the wakefulness mechanism. These drugs have lower dependence potential. Daridorexant has a shorter duration of action, hence it is less likely to cause daytime somnolence, which is an advantage as compared to suvorexant. Sedating antihistamines induce sleep through H1 receptor blockade but cause anticholinergic side effects and somnolence after waking up next day. They are not ideal hypnotics, especially in the elderly males. They are sometimes chosen in children to secondarily promote sound sleep while treating a primary reason to use an antihistamine, such as intractable itching. Benzodiazepines are used in anxiety and seizures. Buspirone in chronic anxiety. Hypnotics are chosen based on the type of insomnia. Correct diagnosis guides rational drug selection. For example, Z compounds, Ramelteon, daridorexant and short-acting benzodiazepines are preferred if the primary issue lies in sleep induction, but useless as anticonvulsants. Benzodiazepines are used for allaying anxiety before surgery, as muscle relaxants, alcohol and narcotic withdrawal, acute mania, and hyperexcitability states. GABAergic drugs require gradual tapering. Abrupt cessation can cause seizures and severe withdrawal. Dose reduction should be slow, typically 10 to 25% every 1 to 2 weeks, with behavioral support and monitoring for rebound insomnia. Before prescribing a sedative hypnotic, assess age, fall risk, respiratory disease, liver function, early morning activity needs, and history of substance abuse. Because patient factors are as important as drug properties. Insomnia must be categorized into sleep onset, sleep maintenance, mixed, or circadian rhythm disorder. Drug choice follows this classification and associated conditions, such as anxiety. This slide summarizes rational hypnotic selection. Z drugs for sleep onset, orexin antagonists for maintenance, Ramelteon for circadian disorders, and benzodiazepines only when clearly indicated. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!